Thank you, Dr. Elan, for including me in your course. This topic is very vast, like covering each and everything, so I will be quickly skipping the slides. So cataract surgery is no longer removal of the lens. It is cataract refractive surgery, where patients do not want glasses even for reading. So this is the crux of this study. So what gives us this confidence? So accurate IOL power calculation, advancement in IOL design, advancement in surgical equipments, good quality surgery with proper implantation of lens in the bag, and proper evaluation of the patient for comorbidity. So if comorbidity is there, we don't consider it for 20/6 vision. So IOL calculation, this is the basic of if this is not correct, whatever good surgery you do, it is not going to work. So all these things are there, keratometry, axial length, AC depth. Now in addition to that, all the newer formula includes lens thickness, effective lens position, white to white and corneal thickness. Now here if you see, the effective lens position is the co-founder which is causing the problem. It's caused 35%. Other factors are there, but effective lens position is very important. So it has to be calculated. And what are the things required to calculate? You have to see the K value, axial length, white to white, AC depth, lens thickness, and then the IOL type also. Like when the IOL is coming forward or anterior bowing, posterior bowing, all these things you have to consider. And then as we're discussing, the rexis should cover the IOL properly so that you do not get decentered. So I'll just skip. So IOL calculation, it's very important to understand this. The 1 millimeter change will cause 2.5 diopter change in IOL power in normal patient. So if the eye is very long, then this will come down. But if it is short, it is going to jump. So we have to be more careful when we are calculating for hypermetropic or hyperopic eye, and always measure both the eyes. And if you get difference of more than 0.3, you should redo that, and you can ask the other people to confirm it again. So biometry, as you all know, we have ultrasound and optical biometry. There are many types of them. These are all. So contact, we are no longer using that. Most of the time we are shifting to the immersion one. Why we don't want to use that? Because the compression factor or in the fluid interface, because of these two, the axial length may increase or decrease. So in this slide you can see, this because of the compression, the AC depth has come down, and this has affected the axial length. So nowadays most of us do not see this, these things. Optometrists or technicians will be doing. So when we see all these things, then we can improve over that. Now here, if this is lower than the anterior capsular spike, then this proper alignment is not there. So immersion is still very important, because most of the time optical biometer cannot take care of hard cataract or media opacity. In that we have to come back to the immersion, and it has very good results also. This is a small video showing the immersion, how to do. The ultrasound probe is inserted into the shell such that the tip is almost 5 to 8 millimeter away. So there is no compression or fluid interface in between. Ask the patient to look straight with the fellow eye to fix at the distant point. If patient is one-eyed, you can ask him to look at the thumb and gently move the probe so that it is aligned properly to the macula. And the machine will start taking the reading. And then you can select the most common reading we are getting in that. So this is a beam you get in the immersion biometer. Here again, if the cataract is dense, you have to increase the gain of the machine. And if the aphakic patient is there or pseudo-aphakic is there, then you have to reduce the gain. If gain is too high also, then the beam will be merged. So here you have to reduce the gain till you get a separate beam in each. Here the retinal spike is not straight. So these are very minor things. If we see this, our biometry will be much better even with the immersion one. And if the beam is aligned with the optic nerve, then you will not get the scleral beam. Or so this is like the advantage of immersion, and it is almost comparable to the optical biometer. The only thing we have to understand when we are using immersion along with like lens star or that, then you have to, the A constant will change because it will go up to the internal limiting membrane while the axial, this one is up to the retinal pigment epithelium. So optical biometers are highly accurate, non-invasive, currently gold standard, and I think first IOL Master came in 1999. Advantage, as we were discussing, measure till the Brooks membrane, while the ultrasound biometer measure up to the internal membrane, and the retinal thickness comes around 160 to 400 micron. So you have to guess this for even making the A constant for in adjusting the A constant. The precision will definitely be much better with IOL Master. So these are the few things in pseudophakic, aphakic, staphylomas, silicon oil. In this, you have to do adjustment in ultrasound biometer, while optical will be taking without this. So definitely optical will be better in that. So there are three types of optical biometers we have, and this study shows that there is no clinical significant difference between the three biometers. So all are good, but if you see this, the repeatability and reproducibility of swept source optical biometer was excellent, and agreement with the standard biometer was very high. Better lens penetrations, ability, and the IOL measurement, axial length measurement were obtained with the swept source biometer with the standard biometer. Now the cost factor is very important. So seeing the cost factor because swept source is very costly, so everybody cannot, and we are still the IOL Master and lens star, and they are giving very good results, so we can still. Now keratometry is measured the center 3 millimeter of the cornea. The important points we have to look into that is the average keratometry is around 40 to 50 micron. One diopter of keratometry change will cause almost one diopter change in the IOL power. Now hard contact lens nobody use, but the soft contact lens definitely you should remove 2 to 4 weeks prior, and should not instill any eye drops before doing keratometry. And keratometry should be done before axial length. Though these are different types of keratometry. This is very important when you are selecting the keratometry from different machine. The power will change according to the central area, how much it is taking. So lens star take around 2 millimeters. So here you can see the keratometry value is higher than the 3 millimeter which is taken by manual keratometry, 3.2. So almost 0.5 difference is there in this. So when you are changing the machine and using the other machine, adding, then we have to take care of this. Dry eye, as Dr. Arvind was talking, it is very important to look into the dry eye because it itself changes the cylindrical power. So now in this case, the same patient, the cylindrical power of 1.5, and after treatment it comes to around 0.3. So this is very important factor when you are going for higher end lens. The corneal irregularity is also very important. So if we have pentacam or
faster.
Okay. So the aberration, like already the trifocal lens will have aberration, and if cornea is already having aberration, it's going to compound it. So we have to be careful with that. Now formula already we know. This is the every presentation we see that for normal case all the formulas are good, but in extreme cases, the Barrett's, Olsen, and nowadays latest formula Hill are better in that. So Barrett's formula in this study was shown that it is better than the other one when they are comparing the IQ Alcon lenses. Well, this study Keynes seems to be most accurate. This is artificial intelligence based formula. But as the Barrett is easily available online, you can take. So we have to understand that when we are doing this multifocal and trifocal lenses, we should not rely only one formula. We can take 2, 3 formula and then we take the result. This is a small video, like just to show the centration of the lens. I, being a cornea surgeon, I don't want to make too much port, so I make only one port for the entry. And I don't do cortical aspiration. So I will remove everything in one go. So what is behind this? So what I will do is I will separate the anterior capsule. This is one additional steps, but it's very simple, just one sweep And when the capsule is separated, you do just a proper hydrocortical delineation, and now the nucleus will rotate along with the cortex. So it's moving along with the cortex. Now when you do phaco, everything will come along with the. So there is no cortical matter remaining. Everything is done in one go. You can just implant the IOL. Rex's size is again important. We have to, if you want it has to be fully covered from all the sides, it has to be 4.5 to 5.5. Thank you.
Thanks a lot, Dr. Shahbaaz. That was a very good thing, whatever you said. Immersion is almost equal to the optical biometer when done in the right hands. We'll have more questions in the end. Now I call upon Dr. Kumaran. While he prepares his slide, one more question for you. Of the optical biometers available, you said there are 3 categories. Which is your choice for a practitioner, not for a...
See, as this study shows, swept source is better than the other 2, but the cost factor is too high. So as an individual practitioner, I will not go for swept source. I will still be with Lensa Star and IOL Master. 500 is equally good. So there are some cases in which you feel that, in that we can do immersion itself.
Immersion. Thank you.